Very good afternoon, one and all. I'd like to welcome all of you to today's ISCCM STEP and Structured Training and Education Program for nurses. The topic for today is tropical infections in ICU, a case-based discussion. It's my pleasure to introduce our speaker, Dr. Himaaldev GJ, who is the head of Department of Critical Care at Apollo Hospital, Sheshadripuram in Bangalore, and he's here to give us his perspective and his vast knowledge and experience in dealing with these extremely complex patients. So over to Dr. Himaaldev for the discussion. Welcome, sir.
Yeah.
Welcome, everybody.
Thank you, Dr. Dipali, and thank you, Step and Program, for inviting me for this session, which I felt is an important one for all the nurses to know, because this is what we face every day. And one more thing, incidentally, Dr. Dipali and had a first discussion about one of the similar cases, So,
yes.
So we'll start with the session. So as I go along, it is more of a case-based discussion. So it will be an interactive session, and I would be happy if somebody can mute themselves and ask me questions so that we can clear off all the doubts in that. So let us start with this.
We also have a chat box, so all of you can put your questions up in the chat also. We can take it step by step, right? Yes, please, Dr. Himma, please.
So, tropical fever, what do you mean by tropical infection or tropical fever is, this sort of infections are mainly restricted to particular areas called as tropical areas. They are the endemic areas. So in these areas, these sort of infections are quite common, and that's why the history is very important, especially the history of travel or history of working at these places, and the presentation also. So the common tropical infections, what we see in ICU, which requires ICU admissions, are generally, dengue, leptospira infections, rickettsial infections, plasmodium, that is malaria, salmonella, which we all know, which causes typhoid. Others are chikungunya and cassino-fevrous disease, which are not very common, but these are the common tropical infections. You can't go through all of this in one single hour. So I selected one case. As we go along, we can discuss about the case, and we'll know, because this is one common case which we are seeing routinely, and it has got quite a significant morbidity and mortality. So that's why there should be a high index of suspicion. And also, you need to start treatment early so that you can save many patients with these kind of infections. So remember, these are the tropical infections which we commonly see in our intensive care units. And a few things about this, all these infections are having similar symptoms, and they're difficult to differentiate. And they involve most commonly one or more organ systems. That's why they need the intensive care unit treatment. And if there is any delay in diagnosis and treatment, the chance of mortality is higher. That's why we need to have a higher degree index of suspicion and start the treatment early. So I would like to call it as the DASH files. You'll come to know what it is, what kind of organism it is. So let us go through the history. With the history only, you can understand what exactly we are talking about, So there was a 33-year-old male who came to us. He didn't have any comorbidities. So he had a history of fever for 1 week, and he had rashes all over his body, which was almost a duration of 5 days. And he had altered sensorium since 1 day. So he was initially treated at Raichur, which is one of the states in Karnataka, and one of the districts in Karnataka. And he was initially treated as dengue because he had a thrombocytopenia. And prior to that, he was working in Chikmagalur, which is endemic for all these tropical infections. Okay, so now we know the history that he has working in one of the endemic areas, and he was being treated as dengue infection because of thrombocytopenia. And he was actually treated in a smaller hospital, so much investigation was not done. So later, he was referred to our hospital, but he had 3 episodes of generalized tonic-clonic seizures during his transit. So that's why he was intubated outside only, and he was shifted later to our ICU, and he was taken up into intensive care unit. When he came to us, he was in altered sensorium, but he was moving all the 4 limbs. He was hemodynamically stable. His blood pressure was stable, didn't require any support. Oxygenation was normal. So then we moved on. This was the rash which we found in him when he came to us. Remember, it's already almost 5th or 6th day from the onset of symptoms. So what kind of rashes, when you see this rash in your patient, what do you think it is? So I'll put up the some of the options for you. Do you think it is a tropical infection rash, or this kind of rashes sometimes can be seen in sepsis, which we call it as purpura fulminans when they are very sick? Some of the patients also will have meningococcal meningitis, which can present with florid rash called meningococcal rashes, and some other what you call vasculitic lesions like thrombotic thrombocytic purpura and hemolytic uremic syndrome are common, and we can also see in DIC. So what do you think this rash could be? Can anybody answer the question? Anybody can unmute themselves and answer the question.
Any of the participants want to volunteer and answer? What is the most likely cause of this rash? We really want to make this interactive so that all of you stay awake during the whole session. Yes, so somebody has answered in the chat box that it's probably a tropical rash from the history and the presentation.
Correct. So rightly pointed out, because if you know the history of working at an endemic area, history of fever, rash, altered sensorium, all fits into symptoms of tropical infections. So my first probable diagnosis is tropical infection. But mind you, these rashes, this kind of typical rashes, if you Google it or you look at the images, you can see this kind of rashes in all these options. When the patient has severe septic shock, they develop purpura fulminans, they can have this rash. Meningococcal infection, yes. TTP, HUS, yes. And DIC can also present as these kind of rashes. So when we look at the investigation, we can actually rule out other options and find out what is the cause of this rash. So what happened was, initially when he came, he was hemodynamically stable, but over the time he became progressively hypotensive. And what do we do when the patient becomes hypotensive? We start with fluid resuscitation. We give him fluids, and we always use the dynamic indices, what we call, we use the IVC indices or some passive leg raising test and all those things to guide the fluid assessment. We don't give it blindly because too much of fluid is bad for the patient. So that's why you have to be very judicious in giving fluids. So we resuscitated with adequate amount of fluids. And since the fluid requirement also didn't bring up the fluid resuscitation, didn't bring up the blood pressure, we started him on vasopressors, that is noradrenaline support. So indicating that this patient is going into more of a sicker phase, And we did an arterial blood gas analysis which showed metabolic acidosis, but he had a good urine output and his oxygenation still remained normal. So here he went into hypotension, but his output and oxygenation remained normal. This was the investigations when he came and we sent, and we got the reports. His hemoglobin was normal, counts were okay, platelets were 30,000. Renal function test, that is BUN and creatinine, was almost normal, little bit of rise in BUN. And if you look at the liver function test, there was a little bit of increase in bilirubin level, and you can look at the AST and ALT, that is the liver function transaminitis, increase in transaminitis. But his coagulation parameter like PT, APTT, fibrinogen, INR was normal. We got an echo and ultrasound also, which was normal. So here, if you look at it, there is thrombocytopenia, there is altered liver functions, mild derangement of BUN. Otherwise, there is no coagulopathy, and his other systems are fairly normal. So generally, what do we do when we get this? We send them for a workup along with this all lab parameters. We also send them for routine tropical fever workup. So what did we do was we sent a dengue test, which we send as a dengue ELISA test. We also check for leptospora IgM tests. We have to cover the malaria, so we had to test the malarial antigen test. We also send routine culture before initiating antibiotics. So, and there is generally nowadays, this was a little bit of earlier case, so we had to send something called as a whale Felix test, which actually used for the detection of rickettsial infection. So these all tests, which covers all tropical infection, was sent. Along with it, we sent a blood culture also because we wanted to rule out sepsis. And then we started him on antibiotics. So these are the antibiotics we generally start them when we suspect a tropical infection, which covers most of the tropical infection diseases, because the symptoms are almost signs and symptoms are almost similar, so it is very difficult to differentiate between what kind of infection it is. So we need to cover them empirically with these two drugs. So ceftriaxone and doxycycline covers most of this infection. That's what the initial empirical therapy was. We continued with ventilation and vasopressor support, and since he had also had convulsions, he had to start an anticonvulsant. So after starting all these with general good ICU care, general good ICU care involves all your fast-track maneuver, a good feeding protocol, enteral nutrition was started immediately, a good analgesia and sedation because he's on ventilator. Thromboprophylaxis we couldn't give because of thrombocytopenia, but we had to put him on a mechanical DVT pump. Okay, a regular head end elevation, stress ulcer prophylaxis, and a good glycemic control. These are very important in the nursing perspective of care. So this was continued. And if you look at in next 48 hours, his blood pressure improved. He was taken off noradrenaline. His platelets improved to 80,000. Liver functions also gradually improved, but there was no improvement in sensorium. But he was moving all the four limbs, but he remained to be in very agitated state, altered sensorium. So what's the next thing we did was, we did an MRI brain. MRI brain showed there is something called as temporal lobe hyperintensity, which is actually suggestive of HSV encephalitis, which is characteristic of herpes simplex virus encephalitis. Since the platelet had gone up, we could do the LP, lumbar puncture. Generally, when the patient comes with fever, seizures, or altered sensorium, we generally think of meningitis as one of the differential diagnoses. So that's why we have to do a lumbar puncture. And during the lumbar puncture, this is what we got. We got a high protein. Generally, we check for protein, cells, and glucose levels. It will guide us what kind of meningitis it is. So when the high protein was there, cell count was 200, which was high, and it was lymphocyte predominant. All these are suggestive of viral encephalitis. Generally, it is the herpes simplex virus. So that's the reason we added him on acyclovir. So a little bit of confusion. He presented as tropical fever, but the CSF study showed more of a HSV, herpes simplex. So two diagnoses right now. So we started him on ceftriaxone, doxycycline, and acyclovir. Ceftriaxone and doxycycline to cover for all tropical infections, and acyclovir to cover for herpes simplex virus encephalitis. Let us move further. This was the characteristic finding. You can see the temporal lobes. You can see hyperintensities. This kind of MRI picture is seen in generally in HSV encephalitis. So there were two evidences for HSV. That's why we started on acyclovir. And as the days progressed, you can see a conjunctival hemorrhage here. And you can also see a lot of gangrene developing in the digits. Okay, you can see the rashes. Rashes are becoming more pronounced, and you can see the gangrene there. So it looked like more of vasculitis. So again, one more diagnosis came in. So vasculitis profile was sent, which was negative. So now he has a tropical fever picture with thrombocytopenia and altered LFTs and shock, which is recovering from. Second one is he had altered sensorium, looking like HSV encephalitis, and some vasculitis picture. All of this can be explained with one infection? We will see it in the further slides. So what we did was, we sent dengue profile initially, we sent leptospira profile, we sent malaria profile, and we sent Whale Felix on the day of admission, which all came as negative. Even salmonella was also tested. Blood culture also came negative. So all this tropical infection panel was negative. So you don't have to depend on these investigations. Based on clinical picture, you can start the antibiotics, and high index of suspicion and clinical presentation is very important. But what we did was, after 1 week, we repeated this test. This is called as a Whale Felix test. This is usually done for identification or diagnosis of rickettsial infection. It is basically nothing but the antibodies which are directed against protease is detected, and this cross-reacting antibodies also detects the rickettsial infection. So we have three titers here: OX19, OXK, and OX2. Usually 1:160 titer is taken as significant. So if you look at it, OX19 and OX2 are significant. That means initially when we did the Whale Felix, it was all negative. The titer was not, it was only 1:20. But after 1 week, he repeated this test, it came as positive. So this is what is important. So generally, in the first week, all these tests can come negative because the antibodies would not have produced by these infections in this first initial week. So when we repeat this test, you can get this antibody detection and it will confirm that it is a rickettsial infection. Okay. So generally, when the first test comes negative, you have to repeat it serially to look at the rise in titer. If it is 1:20 initially, it has to go up to 1:160 and above. That indicates that there is definitely a rickettsial infection. Okay. So now the infection is confirmed that it is a rickettsial infection, and we can continue with doxycycline. Remind you, doxycycline is a drug of choice for this rickettsial infection, including leptospira and most of the tropical fever infections. So that's why we empirically start with doxycycline along with ceftriaxone to cover for other tropical infections like typhoid. Okay, I hope this is clear till now. Any questions about this? You can unmute and ask, and we can go further. Any questions in the chat box?
You can put your questions in the chat box also, and we can discuss those. So far, basically, we've discussed about how these topical infections present, the kind of organ systems that it can affect, and how is the testing done, preliminary testing as well as subsequent testing when the preliminary testing is negative.
Great. Dr. Dipal summarized it right well. So right now, we have a diagnosis. It is a tropical infection, and it is a rickettsial infection because Weil Felix test is positive. Okay. So this is what I told you. This is what Weil Felix does it. We don't go into the detail. It has got a poor sensitivity, but it is reasonably specific. So you can actually, after 1 week, if there is a rise in titer, we can actually trust this. But remind you, Weil Felix can be false positive. It can be falsely positive if the patient has been vaccinated previously, if he has a urinary tract infection with Proteus, or if he has a typhoid, infectious mononucleosis, or brucella infections also, it can be false positive. So it has to be actually compared with clinical presentation as well as signs and symptoms and correlated well. And nowadays, we have a recent tests, which we don't only rely on Weil Felix test because it has got not a great specificity. We have something called as a PCR test, which I'll tell you in further slide. This is how we determine the Weil Felix test, So rickettsial infection these are the variants of rickettsial infection. They have different names for this. Depends upon what kind of organism is it. Generally, it is caused by rickettsial, what do you call rickettsia or oriental Tsutsugamashi organism. We have Rocky Mountain spotted fever, rickettsial pox, epidemic typhus, endemic typhus, and striped typhus. In India, striped typhus is more common. But unfortunately, what I had shown you the slide, his OX19 was high and OX2 was high. So if you look at these two, it fits into what we call as Rocky Mountain spotted fever, which is not very common in India, but still it is possible. But the treatment is same for all these rickettsial infections. If you put doxycycline, that will cover almost all of these infections. But nowadays, there is a possibility that some patients can develop resistance to rickettsial infection, can develop resistance to doxycycline. So at that time, we have to use some other alternative like macrolide antibiotic like azithromycin. Sometimes we also use something called as rifampicin also. So these are the treatment options for this treatment, and based on this Weil Felix titers, we can know what kind of organism it is, just to isolate what kind of organism it is. Okay. So this is the test which I was talking about. It is a PCR test. I told you first when we did the Weil Felix, the first week it was negative because antibodies were not produced. So we thought it was not rickettsial initially. That's why all those confusion of HSV encephalitis and other sepsis, septic shock, all those things came into our mind. But if you had done a PCR initially, the PCR can be detected even in the first week itself, as soon as the patient comes, and it is faster. You'll get the test easier. It is not available in all the hospitals. That's why people generally go by symptoms, clinical presentations, history. History is very important. That's why we insist on history. But if you have an option of doing a PCR test, you can send it for PCR panel. We have a tropical PCR panel nowadays. You get the result within a day, and you can treat them accordingly. Okay. Basically, it detects the rickettsial DNA in whole blood sample. And we have something called Yeshkar, which I'll show you the picture. That is a skin lesion. You can take the sample from them that also and send it. for a rickettsial PCR. Okay, as I told you, within the first week, if you send, it is it is useful because rickettsemia is very high in case of in the first week, and you will get the diagnosis also earlier. So what happened to this patient? I told you his blood pressure improved and his liver functions improved. But later, he used to have some fever episodes. So what we did was we revised all his lines, because whenever the patient is in ICU, when he is on ventilator, when he has got a lot of lines, you always have to do daily assessment of this patient. What is the reason for his newer infective episodes? As a nurse, these are very important for us. So you need to make sure that you do daily assessment, how many days of lines, and every day we need to have a protocol for this inspection of these lines, and what if there is an infection, what is the next policy. So what we did was, it was already many days, and it looked a little bit of infected signs around the thing. So we revised all the lines. We sent repeat blood cultures, urine cultures, which was negative. And what we did was, initially based on the CSF initial panel, we started on HSV encephalitis, and we sent it for something called as PCR panel. CSF also can be sent for PCR. It came as negative for HSV, so we stopped the acyclovir. Why? Because rickettsial infection can explain all the whatever symptoms and signs we saw. It can explain everything. And his sensorium improved eventually, and he was actually extubated from the ventilator. He was discharged from the hospital without any further complications. His all organ functions recovered, and that's how early diagnosis and early treatment helped this patient to get better faster. Okay. So what was the final diagnosis in him? It was actually a rickettsial infection. It was a Rocky Mountain spotted fever, which went into multi-organ dysfunction. Why I call multi-organ? Because he had a liver function derangement, he had shock also, and he had vasculitic lesions. That's why multiple organ. That's why he required an ICU admission. And he also had something called as encephalitis. So this can be related to rickettsial encephalitis. So this is the diagnosis. This is how we evaluate the patient of this tropical fever infection, based on clinical symptoms, based on investigations, ruling out other causes, and proper ICU care. You can actually salvage these patients better. Okay. A little bit of just a background on rickettsial disease. If you see, I told you it's an endemic disease. That's why it comes under tropical infectious panel. So it's endemic in certain states. You can look at Kerala, Karnataka, and Tamil Nadu. And I told you, in India, scrub typhus is most common. And untreated cases may land up with multiple organ dysfunction syndrome, and mortality is 30 to 45%, which is very high. That's why you need to detect them early, and empirically you start them on doxycycline. Sometimes we think if it is a resistant organism, then we might have to start them on a macrolide like azithromycin. These two things you need to remember. Okay. So these are the culprits. What are these? Have you seen one of these? People who have pets, I'm sure, definitely would have seen this. These are the ticks. They are the vectors. It's caused by rickettsia, but rickettsia is harbored by ticks, and these ticks are the ones which goes and bite the humans, and they are the ones who transmit the infection to the patients. Patients history-wise, if you ask the history, that day I have gone recently to a endemic area. I worked in all these vegetating, like all these plantations, or I've gone to an estate and I've worked there. I've gone in that high grass areas, or I've come in contact with some of the pets or animals like cows, dogs. They're all harbored with these ticks, and when they bite humans, they transmit this particular organism and cause rickettsial infection in humans. These are the different variants which I told you. How you divide this rickettsial infection. You don't have to remember all these, but remember that louse, mite, and flea, which are commonly seen in pets, are responsible for these infections. There are a variety of rickettsial organism, and vectors are usually rodents, dogs, and mice. So this is why the history taking is very important, but the treatment is same for all these infections. It is doxycycline. If resistant cases, it is a macrolide antibiotic. And if you look at the history, it was first recognized at Snake River Valley, and that's why it was called black measles. And Howard T. Ricketts was the one who actually express the fact the role of tick vectors in transmitting this disease. But sadly, Dr. Ricketts died of rickettsial infection itself. And Lenin during Russian Revolution said that it was so rampant, either socialism will defeat the bug or the bug will defeat the socialism. And rickettsial infection is so much, not only now, previously also in the past, it has taken more lives than all the wars combined together. That was the burden of the disease of rickettsial infection. Unfortunately, probably that time the awareness was not so much, or the detection or the lab tests were not so prominent. That's why we used to miss these infections. But nowadays, the clinical acumen and the laboratory advances have actually improved the quality of detection and treatment aspects. That's why we are able to save many patients. This is how the rashes appear. The rashes which I showed you was initially when I showed you the rash, it was more pronounced rash. But this is how it starts as a petechial rash. It can become purpuric. Sometimes it can become palpable purpura like vasculitis. It starts in the peripheries. It starts in the hand and the legs and slowly moves towards the trunk. Okay, and so this is the same thing which I've told you. It forms as a pink blanching discrete mercus and becomes more pronounced later. And I told you it can become gangrenous also because of the vasculitic lesion, because rickettsia can cause vasculitis of the vessel wall, because it actually affects the vessel wall and the reticuloendothelial cells. That's why there can be gangrene of the digits. It starts at ankles, lower legs and legs. It goes towards the whole body. And presence of rash on the palms and soles are typical of rickettsial disease. You can see the rashes in palms and soles. Other than rickettsial, you can also see in infective endocarditis, syphilis, and meningococcemia. So rashes distribution is also very important. But if rashes are not there, it doesn't mean that he doesn't have rickettsia. Remember this. This is one of the important take-home point. I don't have my patient has a fever, patient has thrombocytopenia, but there is no rash. Oh, it's not rickettsial. It doesn't mean that way. Rash need not be there always. It can be present, it can guide you, but the absence of rash doesn't mean that this patient doesn't have a rickettsial infection. Okay. So this is one pathognomic feature of rickettsial infection. Can anybody tell what it is? I've already written it down there, so it's fine. It's called eschar. So wherever the tick goes and bites the human beings, you get this lesion here. Okay. So this is all. This looks like cigarette butt burn. So that looks like a little bit of erythematous lesion and dry crusted area, and it is not always visible. Sometimes it can be hidden, and you need to examine the patient. That's where the role of nurses are very important, because in our center, I think most of the times the nurses are the ones who detect these eschars and tell us, sir, I can find an eschar here, and it could be a rickettsial infection. Because I told you this fever, rash, altered sensorium, liver involvement, kidney involvement can happen with so many other problems. But to detect this particular, to suspect rickettsial infection, you need to have all these evidences. So here sometimes you can see it in between the hidden areas. It can be seen in the nape of the neck, or it can be near the joints, or it can be on the back, underneath the breast, groin areas, between the buttock areas. You cannot really identify it sometimes. So you need to look for it. You need to turn the patient, look at inspect the entire back of the patient, look at all these hidden areas, and look for this eschar. If the eschar is present, it is actually a good pointing out feature that this patient has a rickettsial infection. Commonly, what we saw is a scrub typhus infection. So eschar is important. Just reiterating the fact that this is a classical triad: fever, rash, headache, or altered sensorium. Rash develops from day 2 to 5 of illness. I told you 10 to 15% of patients are without rash. So don't worry that rashes has to be there. Along with that, some of the other features which you can see in these tropical infections or rickettsial infection is they can have hyponatremia. They can have thrombocytopenia, which is very common. And I told you they can have liver derangement and kidney dysfunction. Okay. And they can also have CSF features of encephalitis, which we discussed before. Treatment should be started immediately. Doxycycline is the drug of choice. We give 100 milligram twice daily for 10 days. Sometimes some resistant infections, rickettsial infection, require second line drugs. Like I told you, we use macrolides, chloramphenicol, sometimes rifampin also. And the characteristic feature is you see this patient, you saw our patient also. Once we started the treatment, his blood pressure picked up, his kidney functions improved, liver functions improved, his altered sensorium got better, he got out of the ventilator. So rapid defervescence, rapid improvement is a characteristic feature of this rickettsial infection. But some patients, they can really go into florid multi-organ dysfunction syndrome if you start the treatment later, and usually you will lose the patient because the mortality is very high if you start the treatment later in these patients. And once multiple organs are involved, the chance of patient coming out is very lesser. And I told you there are a lot of gangrenous areas which I showed in the picture. It is because of vasculitis, because it involves the vessel valves, and also it involves reticular endothelial cells. That's why it involves multiple organs. That's why it causes multi-organ dysfunction syndrome. It also causes a lot of edema in the patient. That's why I told you fluid. It's not like water. You keep on giving to increase the blood pressure because it can go into other parts. It can cause a lot of problems. And generally in our intensive care practice, we say more fluid is actually more bad. It is not one day. It is a cumulative fluid balance. Every day you keep on giving more and more fluid to increase the blood pressure. It will not increase the blood pressure. It will cause more organ damage. So judiciously, you have to make sure that the patient is not giving too much fluids, because all these fluids won't stay in the blood vessel, doesn't increase the BP. It will go out of the blood vessel. It will cause a lot of other organ damage. So make sure that you have to be very judicious in giving fluids in these patients, and try to cut down on the fluids. And we use a lot of other maneuvers. I'm sure doctors can tell you about the bedside maneuvers of assessment of fluid requirement. And we always have vasopressors like noradrenaline, vasopressin, and adrenaline to help us with the blood pressure. Okay. I told you some patients can recover faster, but some patients can go into other complications like disseminated intravascular coagulation. They can form clots in all the places, or they can start bleeding. And this will generally cause a lot of problems, and patients will have a higher mortality. They can also go into a lot of vasculitic lesions and gangrene, which can get infected and cause problems later. So this slide explains what all rickettsial can cause. It can cause gangrene, it can cause lung ARDS, it can cause liver derangement, it can cause encephalitis, it can cause renal failure requiring dialysis. So the more organ it gets involved, the more chance of death in the patients. So finally, the take-home message is ticks are awful. Okay, if you see one, you will know one. And the low, you need to have a good suspicion. You need to generally what happens is we have a low index of suspicion, non-specific signs and symptoms, and absence of widely available tests. That's why it becomes difficult to diagnose. So we don't have to wait for these tests to come and start the antibiotics. You send the workup. Always, before starting any antibiotics, you make sure that you send the workup, especially the blood cultures, and do not delay the antibiotics. Try to give the antibiotics as soon as the patient comes to you. No? And along with that, not only antibiotics, make sure you resuscitate the patient and follow all the ICU bundles, and make sure the patient doesn't develop into secondary problems while staying in the ICU. Failure of timely diagnosis leads to significant mortality and morbidity, which I told you already. With timely diagnosis, treatment is easy, affordable. It's not very expensive treatment at all. Doxycycline is cheaper, and often there will be a successful dramatic response to these antimicrobials. There will be a rapid effervescence, and they get better very fast. Okay, so that's about the tropical infections. I won't go into details of dengue, leptospira, because it's a different topic itself. So I'm sure this particular lecture has helped you understand what kind of infection burden can cause rickettsia and how do you tackle it. And the final question for the audience is, what is this slide? It was in the lecture. Anybody?
You can answer in the chat box too.
So it is a Rocky Mountain. Okay, so this is the Rocky Mountain. Just to tell you that this infection was a Rocky Mountain spotted fever. Generally in India, it is not very seen. It is seen actually outside country. And the Whale Felix test or the rickettsial PCR can detect these tests and help us to guide the treatment. But the treatment is the same, which is doxycycline or a macrolide antibiotic. A recent study has come now that using two antibiotics like doxycycline and macrolide versus one antibiotic, there's a lot of conflicts in that. But generally, a single antibiotic like doxycycline would do for most of the patients. But sometimes we do get the resistant rickettsial infections where we have to use other antibiotics like other alternatives like azithromycin and chloramphenicol. Okay. So I'm happy to take up the questions, ask more questions so that we can discuss any queries we can discuss.
Do any of the participants audience have any questions? I think that was thank you, Dr. Himal. It was a very comprehensive talk on rickettsial infections, especially because it's something that is not very much, it's not very something that the general public themselves is very familiar with. It's easy to counsel a family and tell them your patient is suffering from dengue or malaria, but you say rickettsia and there's always a question on the face. They don't then nobody's really familiar with it, despite the fact that how common the disease is, especially in certain parts of Andhra and Karnataka. We see a lot of patients from a particular belt. I think awareness really needs to increase regarding rickettsia, more so because the treatment is so simple, and the earlier you give the treatment, the response to the treatment is so rapid, and any mortality from rickettsia is definitely avoidable. If it is just treated at the primary level, it shouldn't even reach us. It should be identified earlier, it should be treated earlier. In an ideal scenario, it would never reach us, considering how quickly most of these patients respond to treatment. So it's a very important topic. Does anybody have any questions regarding rickettsia? I'm sure you have faced patients or treated patients with it or a similar syndrome. You may have questions how to differentiate, how to diagnose, anything that was discussed here, or anything regarding anything else regarding tropical infections, if anybody wants to talk about or discuss with us else regarding tropical infections.
Ma'am, there is one question in Facebook Live.
Oh, is it okay?
That question is that why hypotermia similar to meningococcemia? Why hypotermia similar to, because we can't understand the question.
Just try to access it.
Are they asking why the rash is similar to meningococcemia?
Ma'am, please open Indian Society of Critical Care Medicine page.
Yeah, I'm trying. Actually, I didn't log into Facebook. I'll just try to do that. If you can share a screenshot with me, I can try to.
Somebody has asked me, any other choice of antibiotic is possible?
I think there's a question in the chat box also. Sir, any other choice of antibiotic is possible?
Yeah. So that's why I think it's a good question. See, the drug of choice for rickettsial infection is. Can you hear me? Can you hear me, Dr. Dipali?
Yes, I can hear you, Dr. Himal.
Yeah, so the drug of choice for rickettsial infection is doxycycline. Only in resistant cases, we can use antibiotic azithromycin, and sometimes we can also use chloramphenicol. When everything is resistant, there is no response. Sometimes we can also use something called as rifampicin. But I think the person who asked this question, I think some physicians, they follow the routine practice of using a piperacillin, tazobactam, or a carbapenem, or a higher antibiotic, thinking that if I use a higher antibiotic, I can get a better outcome. No, the basic antibiotic is the one to go, especially in rickettsial infection. Your carbapenem antibiotics or your BL/BLA antibiotics are not very effective. These are the group of antibiotics which are meant for these infections. So these are the antibiotics which are well tested and tried. These are the ones to be used. It is not the higher antibiotics which is going to help the patients.
Any other questions?
Before starting the antibiotics also, you do not delay. It is all based on the clinical signs and symptoms and the index of suspicion. On the first day itself, here our practice is any patient who comes with tropical infection, we start with the basic antibiotics like ceftriaxone and doxycycline. Sometimes if there is, because they are also present with pneumonia, we also want to cover the atypical pneumonia, we also start them on macrolide antibiotics, which can help both tropical as well as pneumonia panel. Because these are the ones which cover most of the infection. Even typhoid is well covered with ceftriaxone. Because the cephalosporin is the best drug for these salmonella infections. It is not the carbapenem or the BLBLI. And your infection, leptospira, which is also one of the component of tropical fever infections, is also covered with doxycycline, because doxycycline is a drug of choice there also. So if you add this antibiotic choice, you're covering most of your tropical fever infections. Unless you have other infections like malaria, dengue anyway, you don't have any particular antibiotic here. It is more of symptomatic and fluid management and shock management. Even the chikungunya also doesn't have any specific antibiotic or a casein forest disease. It is only you're targeting the rickettsial infection, leptospira infection, and the typhoid infection, which can cut with these three. But if these patients who are staying in the ICU for longer time and they're developing a secondary infection, that's when you consider other antibiotics based on your local antibiogram. Generally, you can go for a higher cephalosporins or a BLBLI like piperacillin tazobactam or a carbapenem based on your shock status or how sick the patient is. But any tropical infection, these are the antibiotic of choice. And nobody can, I think, argue about that.
Sir, the questions from Facebook Live, we'll just discuss it one by one. So I think one of the questions is, why does hyponatremia occur in rickettsial infections? That is one of the questions.
So the basic pathological phenomenon is unknown, because any atypical infection, not only the rickettsial infection, like atypical viral infection also, one of the pathognomic feature is hyponatremia. Probably it's because of the fluid shift from the cells, or it can be because of the hemodilation because of the fluid, but there is no other reason. But it is one of the diagnostic indication. It can help you with diagnosis. Doesn't mean that hyponatremia is the indication. It is one of the because in bacterial infection or any other septic parameter, hyponatremia cannot be there, or any bacterial pneumonia, it may not be there. But in atypical infections or tropical rickettsial infections, you can have hyponatremia as one of the feature, but you not depend on that test.
I think probably one of the reasons, as Sir said, could be the fluid shift itself. So when we have a lot of capillary leak, we're resuscitating. If we use a hypotonic fluid to resuscitate, that could result in hyponatremia. The other possible reason, especially when there is encephalitis or the central nervous system involvement, could probably be SIADH. So if there is like a syndrome of inappropriate ADH secretion, could possibly lead to hyponatremia. But unless the patient is really symptomatic, if you manage the general condition, treat the infection well, that should not be a big problem. It should be manageable with general ICU care and supportive measures itself. I think the other question is role of so somebody has asked role of steroids in the acute phase of ARDS. Is there any role in rickettsial I think in tropical infections in general, especially rickettsial, I would say.
My next discussion was, I thought I'll tell about the steroids. So because this patient had vasculitic gangrene lesions, we thought, should we start steroids in him? But if you look at the evidences and all, there is no role for steroid unless there is a definitive other reason for vasculitis. There is absolutely no role for steroids in tropical infections. Even in ARDS, other than the COVID-19 pneumonia, I don't think there is any further reason to give steroids in all these patients. But nowadays, there is evidence that there severe community-acquired pneumonia, steroids might help. But in an ARDS patient, other than COVID-19, we have not found, or the evidence doesn't say that we have to use steroids as such. As a part of treatment for COPD, probably we can use steroids. But generally, ARDS as such, I would not use steroids.
So actually, from in our center, we are a little more partial to steroids, I would say. This is possibly because of the kind of patients that we're seeing. We're seeing a lot of rickettsia, especially this is the season where it really starts going up, November, December. And one thing that we have seen, and the reason how we look at evidence and prior to giving the steroid, is a lot of them develop this syndrome called HLH. So, HLH basically one of the treatment of choice is steroids. We have seen that a lot of patients who have rickettsia, especially when they have persistent organ failure that's going on beyond 48 to 72 hours after treatment also with antibiotics. It's especially when there's an hyperinflammatory response or hyperimmune response. We have checked specifically for HLH, and HLH can be diagnosed using something called an H score. It is an online calculator. You get it. Very simple parameters can be put in to calculate, get the H score. And in these patients, we have used steroids, and we have found a very dramatic benefit to giving steroids in only this subset of patients. It's not every patient with rickettsia or dengue where this can benefit, but it is this particular subset who has persistent thrombocytopenia, leukopenia, persistent shock, renal failure, not responding, worsening respiratory parameters. And we have seen some benefit with steroids, but this is still under evaluation. It is still under consideration, and I don't think there is any recommendation to give it uniformly to all rickettsial or all dengue patients. But it's something to be kept in mind, especially when your patient is not getting better. But with a small, you have to be very careful while dealing with steroids, because there's a lot of hyperglycemia and delirium that we see along with it. So we need to be a bit careful, a bit wary. It's a bit of it's still unknown territory that we're treading in right now.
Yeah, steroids can be a double-edged sword.
Yes,
so
definitely.
I'm a little wary on the steroids, but rightly pointed out. But the thing to take home is a patient who comes to you immediately, routinely, most of them, rickettsial or any tropical infection, I don't think there is a role for steroids. But if they go into other end of spectrum, like as she rightly said, uh, like HLH, and HLH, sometimes I feel it is overdiagnosed, and I think but if there is a gross deterioration and there is no other the way we can salvage this patient, I'm sure the steroid will definitely help them. You're pushed against the wall, and you take a risk and do it. And so I agree with that. But generally, as a routine, but there is no role for steroids in these cases. And the second one is, other part is, if the patient is in a septic shock and is requiring a very high dose of vasopressors, that's when we generally start them on steroids to come down on the vasopressor support, because this vasopressor itself can worsen the gangrene and the necrosis in this patient. So that's where I use steroids in these subset of populations. Yeah.
Are there any questions in the Facebook Live? Any more questions? These are the two questions we got from Facebook Live. Any other questions, organizer? Because I'm not able to access the Facebook Live. From the audience?
Ma'am, that same person asking another question. It's the duration of antibiotic therapy.
Okay. So I showed it in the slide also. Generally, 10 days should be sufficient, but sometimes it goes up to 10 to 14 days, but not more than that. By that time, because they have got a dramatic response to these antibiotics, there is a rapid effervescence, and 10 to 14 days would be ideal duration for this treatment of choice. But just to stress on the fact that you need to have a very high index of suspicion, start the doxycycline as soon as the patient comes to you along with ceftriaxone. Do not wait. And then probably we can follow up the tests, and maybe we can curtail our antibiotics. If it is not a rickettsial infection, probably change the antibiotics or de-escalate the antibiotics earlier.
Okay, sir, fine. Then there is no more question. That is the last question.
And there is a thing about staining of teeth with doxycycline. People are a little afraid of using doxycycline. But I think the benefit, the problems with doxycycline is, if you look at the risk versus benefit ratio, the response to doxycycline is so profound. I don't think we should worry about all these negative side effects of doxycycline. That's why don't worry, initiate the doxycycline. And especially, I'm sure the lot of crowd is nursing crowd here. Your role is very important in because a doctor examine and goes, because you're there with the patient most of the times. You need to look at the way the rashes are being developed. The way sometimes you might find the eschar in them. So these are the things which you need to notify to the doctors that it can guide them. As I told you here, most of our diagnosis has been done by the nurses, showing that this I can find an eschar. So yesterday rash was not there. There's a rash today, and there's a rash in palm and soles which is spreading towards the uh, center of the body. So all those things are very important. So there is a major role for the nursing in helping us uh, guiding towards the diagnosis. So this can be anybody, not the history is totally very important, because history of association with the pets, and working like farmers, agriculturists working in a high grass area, a recent travel to trekking. Most of them come here and they want to trekking to certain places. It's a classical history, and that's when we don't think about it. You start the doxycycline right away. Dr. Dipali, do you start? Do you in these tropical infections? Do you do a double therapy or do you follow the single therapy?
No, as of now, what we're practicing, so we start off with ceftriaxone and doxycycline to begin with. And if we are not seeing a response after 48 or 72 hours, like I think a couple of years back, there was one strain, we're assuming it was an isolated strain. There were a few months where we saw that there was not much response we were seeing with doxycycline. A group of patients were not responding. So actually, even before this study had come out, we had started treating after say about 48 hours if we are not seeing defervescence of fever or improvement in organ function, especially the respiratory component. Because we see that those who improve, we are able to extubate them really quickly. They come off the ventilator quite fast. They start doing better. So those patients, yes, azithromycin we have tried, but it's not universal. We are not started giving it to every patient. It's more of case by case basis. We're giving the dual therapy. But to start off with, of course, ceftriaxone and doxycycline. In fact, I feel now it has come to a point where we're seeing so much rickettsia that my urosepsis patient is also on doxycycline. Have to come the next day morning and say, "This is a UTI, guys. Stop treating every patient as rickettsia." So now our threshold for rickettsia has become very low. But anyway, it's still something, but that's because we see a lot. But the overall awareness of it, especially, is quite low. I think very important to be able to improve that now.
Even this patient which I discussed, this was a little older case. He was being treated as dengue. They wasted 3-4 days there. Probably he wouldn't go into this phase if he had started doxycycline little earlier. He was not on any antibiotic. If I remember, he was on
Yes.
amoxicillin clavulanic acid, which was not helping him in any ways. That's why the awareness is very, very important about what is the right antibiotic for these kind of infections.
That is the
Somebody
other
asked that
thing
right
is-
question on this.
So there are a lot of cross reacting antibodies also, I think, that are being produced. So a lot of these patients, when tested outside, especially typhoid, we see a lot of them coming in with Vidal positive. And this Vidal positive would have happened within the first week itself, which is quite unusual. But within 4 days of fever and the Vidal is tested, it's positive. So, so they end up getting treated as typhoid or dengue or something else for the first 3-4 days, go into fulminant organ failure, and then land up with us. So that is a very sort of common and very unfortunate thing, actually, because of the how easy it is to treat, especially on an OPD basis. The drug, it's an oral drug, and it's so easy to treat. It's unfortunate.
And remind you, the oral doxycycline and IV doxycycline has got a good oral bioavailability.
Correct.
So I think oral doxycycline also will do the same just as like IV doxycycline.
Yes,
That can be
actually,
an
we
option
have
as
been
well.
using only oral doxycycline unless that is another thing. I mean, if for the participants, because there's a tendency, if the patient is on the ventilator to use IV doxycycline or IV drugs in general. But with doxycycline, the bioavailability is really good unless the patient has extreme intolerance or very severe shock where we suspect that the blood supply to the mesentery or to this may be reduced and the absorption may be affected. If that is the case, then probably IV would be better. But otherwise, oral doxycycline is as good as IV doxycycline in treating it. So that is
So
the
one last take-home point I want to stress was why I did this particular case was this veil Felix test is always confounding. We generally when the patient comes, we do the veil Felix first day as soon as he comes, and because antibodies are not there, it comes negative. So we think it is not like itself discontinue the treatment. That's not the way to go. You need to repeat this test. If you don't have a PCR test, repeat the veil Felix and look at the rise in titer. That will confirm the diagnosis. And other ways, veil Felix, as Dr. Dipali rightly said, there can be a lot of false positive because of cross-reacting antibodies. Even in UTI protease, they can become positive. So don't go by that. You need to have a proper clinical acumen and discussion among various departments. I've seen a lot of physicians also starting meropenem for rickets cell infections, especially in the tertiary, in the nursing homes and all that. So the awareness is also very important.
yes, definitely. Any questions from the participants regarding this? Anything else? I think there are no more questions.
No, ma'am, there is not
Some-
any question in chat box. So we can
Some
wind up the session.
meningococcal question was asked. Were you able to get that? Some meningococcal rash or something.
No, it seems to be a continuation of the hyponatremia question itself. So the question is why hyponatremia similar to meningococcemia? So it seems it's
Okay.
coming
Understood.
phase by phase. So I think it's another few comments